All right, good afternoon, everybody. We'd like to welcome you to our session today and thank you for coming. We want to go ahead and get started as soon as possible because we want to make sure we have time for all the presentations and leave time for questions at the end of the session. But if you have a question during the session and you'd like to come up, please feel free. We do want to just caution you that we want to give as most amount of information that we can, and we've limited to our talks to about 20 minutes each. So my name's Elaine Markland. I'm going to chair the session today, and we're very pleased to have our group from the University of Alabama at Birmingham represented today. We all flew in from Birmingham, Alabama, where we all practice clinically, and by training, I'm a geriatrician. Dr. Patricia Good is also a geriatrician, and Dr. Holly Richter is a urogynecologist. So we're all going to give our different perspectives. And with that, I'm going to turn it over to Dr. Good for our introduction to the epidemiology, pathophysiology, and evaluation of fecal incontinence. And then I'll come back up and present cases and our algorithm and the behavioral and medicine approach to treatment. And then Dr. Richter will do the surgical approach. Thank you.
Thank you for coming. And as Elaine said, I'm going to talk to you about the epidemiology, pathophysiology, and evaluation for fecal incontinence. Well, the green button, I have no disclosures. Our learning objectives for this part of the workshop are to outline the prevalence and incidence data for fecal incontinence from the epidemiologic literature, to recall the anatomy and physiology of defecation, and to recognize the clinical tests for the evaluation of bowel incontinence in adults. Fecal incontinence, we always start with the definition, and the International Consultation on Incontinence has gone a long way to really help us with standardization of terms related to incontinence, but there's still no uniformly accepted international consensus on these definitions, although, as I said, ICI has done a wonderful job, and the last volume was the 5th edition of incontinence. Fecal incontinence is the involuntary loss of feces, either solid or liquid. Anal incontinence includes loss of gas as well, flatus or gas. There's basically two types of fecal incontinence, which are similar to those that we see in urinary incontinence. Urgency fecal incontinence, accompanied by urgency, gotta go, and then passive or just seepage of stool. And it's called all different things. There's more variation in that term. Some people call it fecal staining because the patients are surprised when they arrive in the bathroom and there it is. Some people call it smearing. But basically, there are passive losses of stool where urgency probably has some different mechanisms. There was a group from the United States, the Pelvic Floor Disorders Network, that convened some focus groups and actually talked to patients in the United States now, about what was their preferred terminology for fecal incontinence. And it wasn't fecal incontinence, it was accidental bowel leakage. That was what they preferred out of all the different things it could be called. They also did some work on a conceptual framework for accidental bowel leakage. The things that are normally measured when we do fecal incontinence trials are just all the ones right up here in the top of this slide. Primary bowel leakage symptoms, bowel leakage itself, whether it's solid, liquid, gas, or mucus, how frequently it happens, what the amount of leakage at each episode is, and the bother of the symptoms. We have some pretty good tools for assessing this, and I'll list those in the next slide. But the patients in the focus groups had other symptoms that they were very interested in improving. One was conditions when bowel leakage occurred, both the predictability, if they knew when it might happen, they felt a lot more reassured than if it was just totally random in their assessment. Whether they were aware of when the leakage came out or whether it was a surprise because they could smell it or feel it. And whether it had urgency or not. Urgency itself, even without bowel leakage, is a very troublesome symptom. And the women in this group, and I should say this was a group of women. Men may have a slightly different opinion, and that work really needs to be done. But the urgency is a real bother and affects quality of life. Then there were some ancillary bowel symptoms that were discussed. Emptying disorders that go along. These patients all had fecal incontinence, but they also had problems with constipation, They used the term obstructive defecation. You could also say incomplete bowel emptying. These were patients that really felt like the stool just didn't all get out each time, and that was troublesome to them. And then wiping issues. They'd say, I wipe and I wipe and I wipe and I never feel clean. And that was an issue that they would like to improve with treatments for their fecal incontinence. And then discomfort, how often the symptoms occurred and how the bother of it, but it was pain or burning, both with defecation, but even more commonly afterwards. So let's talk about prevalence rates. How common is fecal incontinence? There's a wide variety of figures from all different studies, depending on the population. In the United States, it's 1 to 25% of community-dwelling adults. About 1 in 5 or 1 in 6 women, about 1 in 6 or 1 in 7 men. You can see 18 to 33% in acute care settings like a hospital. And in patients that were coming in to seek health care for other conditions, it was about 30% in one study. 38% of those receiving home care, they have an increased symptom burden of other diseases. And then in long-term care or nursing homes, more than 50% of patients have fecal incontinence. This is a map that Dr. Markland put together showing all the different prevalences of the different countries. And you can see there's a lot of variety. There's some wide confidence intervals there. But basically, there's a lot of agreement in how common fecal incontinence is in different parts of the world. I have to use the clicker. Oh, I'm so sorry. I have to use the clicker. Now the first part of the recording is all messed up. I'm sorry. Hope you can catch it up. This was a study done on the National Health and Nutrition Survey, which is a population-based survey of adults across the United States. And it's done every year, so it's always cross-sectional data. And the take-home message from this is you can see that incontinence in women starts to go up in the 40s and 50s, and then hits its highest prevalence in older age, which is actually equal to the highest prevalence in men. But men tend to go up more slowly, and then at 70, fecal incontinence tends to pick up. So you can see the difference in the patterns in those two types of leakage. I'd use this button if it worked better. Okay. Incidence of fecal incontinence. This is people that develop new fecal incontinence. They don't have fecal incontinence, and they study them over some period of time, and it's who develops it. It was 6 to 17% overall over 4 to 9 years. And you can see the second study down over 4 years showed that 6% of people developed at least monthly incontinence, and 17% developed any incontinence over the 4 years that they followed them, any incontinence being within a year. And then over 9 years, a different study showed a 6% incidence of new fecal incontinence. There are more studies about postpartum fecal incontinence. This was a 12-year prospective cohort study that was multi-center, and they followed women after childbirth, and you can see that it was 8.2% at 3 months, 9.7% by 6 years, 12.9% at 12 years, and overall 19.9% of women in the 12 years following their delivery developed bowel incontinence or fecal incontinence. Oops, green arrow, green arrow. There's a conceptual framework for risk factors that was put forth by Landefeld et al., which was from a State of the Science conference on prevention of fecal incontinence and urinary incontinence, incontinence in general, thinking that the factors to consider are physical status, age, obesity, activity, genetic factors, neurologic and psychiatric factors, traumatic factors like surgery, and then obstetrical injuries. Disease burden, comorbidities. Incontinence is more common in patients with more comorbidities. And then bowel symptoms themselves that are associated with fecal incontinence, such as diarrhea, urgency, and constipation. So what are the risk factors? You can see them there. The most commonly quoted one of really high impact is diarrhea or loose stools. The odds ratio of having fecal incontinence if you have diarrhea or loose stools is 2.8 to 6.7 times more common. And actually, in the studies that looked at it, fecal urgency is even more of a risk factor. If you have fecal urgency, whether it's solid or liquid stools, you're 5 to 10 times more likely to have incontinence. Irritable bowel syndrome and inflammatory bowel disease are also risk factors. Concomitant pelvic floor disorders, and this is looking at incontinence in women, fecal incontinence in women. If they have urinary incontinence, they're more likely. There also are some men's studies you can see in the red box there. If you have urinary incontinence, you're more likely to have fecal incontinence, odds ratio of 2 to 5 times in women and about the same in men, just the lower border of that 2.3 to 2.6 times. If you have overactive bladder symptoms, urgency, frequency, you're more likely to have fecal incontinence. Pelvic organ prolapse in women is also associated, particularly rectocele, with fecal incontinence and constipation, as we've said before. This is an anatomy slide looking at the mechanisms for fecal incontinence. You can see the rectum, a little arrow, the rectum, the angle that helps hold stool in the rectum that's responsible. The puba rectalis helps hold the anal canal at that angle, and then the sphincters. And there's several different factors here that come up, and there'll be some pop-ups here. Fecal impaction. If a fecal impaction is sitting there, it tends to dilate the internal anal sphincter, and then stool seeps around the impaction and makes patients more at risk. This is a common type of incontinence we see in the nursing home. And then there's stool consistency. Rapid transit is associated with fecal incontinence because there's more diarrhea. And then if you think way above that in terms of neurologic control, cognitive and psychological disorders can impact fecal incontinence. There's sensory elements to fecal continence and incontinence. With afferent nerve injuries, patients can have impaired sensation, sometimes absent altogether and other times just impaired. But on the flip side of that, if they have a hypersensitive rectum and they feel horrible urgency the minute a little bit of stool arrives, that can also be responsible for fecal incontinence, if you remember what a big risk factor urgency was. Little green button will work eventually. There we go. And then there's the anatomic factors related to the sphincter muscle, both obstetrical or prior surgery. Also the puba rectalis, the pelvic floor muscles, they help hold stool in. And if they're injured, which is most commonly during childbirth, there can be incontinence factors. And then pudendal nerve injury, both from neuropathies and obstetrical injuries. And then again, CNS control of the bowels. At any level. Spinal cord injuries, multiple sclerosis, strokes can be risk factors. Now let's talk about assessment of fecal incontinence. Someone presents, what kind of workup should be done? We usually start with a bowel diary. A bowel diary is a very easily administered tool. It's a lot of trouble for the patient, but it gives us an incredible amount of information. They can chart the stool consistency. You can see there the Bristol stool form scale. It goes from hard lumps to sausages to water with no solid pieces. And this makes a lot of sense to patients. They can look at the pictures and decide how their stool looks, and they can easily chart that on a chart. And then you can look over their 5 or 7 day stool diary and get a much better picture of what's going on. And also the frequency of incontinence will be noted in the diary. And there is some data in the urinary incontinence literature that you have to reach a 50% improvement to have any kind of impact on quality of life. It goes up even more at 70%, much more improvement in quality of life. But we need more work on that in fecal incontinence. But for right now, they're using that a lot of times as a threshold, and Dr. Marklin will talk about that a little more. I've listed on the slide the fecal incontinence severity indexes that are validated, the FISI, the VASI, the ICIQB, the Cleveland Clinic Incontinence Severity Index. Different studies use different indexes, which makes it hard sometimes to compare studies. And there's advantages and disadvantages to all of them. And then the quality of life scales are very important to complement the fecal incontinence and symptom indexes themselves. And then once you're finished the history part of it, and you'd obviously do more elaborate history looking at concomitant medical conditions and risk factors, but the rectal exam is very important. You get a lot of information from that. What's the resting tone like? That lets you know that there might be some problem there with sphincter damage. What's their voluntary squeeze strength? Can they squeeze? Can they relax? And then can you feel the puba rectalis squeeze and relax at the same time as the sphincters when they're supposed to? There's actually a validated digital rectal exam. I always forget the S. The scoring system. There you go. I use it in my clinic, every new patient, but I just have dress on there. And it does correlate very well with regular manometry, which I'm going to talk about next. But when they actually tried to correlate it with high-resolution manometry, there wasn't as good of a correlation. Manometry can be a very important tool. I think you can do conservative treatments really well without manometry, but if patients are not responding well, it can be a really helpful tool. And Dr. Markland's going to talk with you about how manometry can be used for biofeedback to assist in treatment. There's a catheter that's put into the rectum. It measures pressures in the anal canal and also in the rectum itself. And you can see that the factors at the very bottom of those bullets, resting and squeeze pressures are important. The rectal anal inhibitory reflex, easy for me to say. The capacity of the rectum, the compliance, does the pressure in the rectum stay low as it fills? And then sensation, can they sense a small amount of the balloon inflation or does it take a much larger amount? And that's all graphed out really nicely, as you can see. And you can chart all different things on this. You can look at the regression amplitude, like here you have them squeeze. How fast does it deteriorate and weaken to be 50% of their maximum squeeze? You can look at how long they can squeeze. There's a lot of factors that you can look at that can be really helpful for measuring outcomes and mechanisms. There's some newer, screen button and I aren't doing well. There are some newer tools that help us with manometry. You can see on the left there the MedSpira system. I'm not trying to promote any one system. There are lots of them. This one's tablet-based, so it's nice, and I think there'll be others that will join it, and you'll hear more about how it can be used for biofeedback. On the right, you see the high-resolution anal manometry, and you can see, looking here on the low rectal, when you have the patient resting, the pressures are low. Then when you ask them to squeeze, the pressures increase. And then when you ask them to push, to do Valsalva, you can see the pressures relax. That's how it should look. But these are very helpful tools to assess patients. And then lastly on our assessment, if the green button will work, there we go, is ultrasound. And again, we don't do this initially necessarily unless the physical exam is really abnormal and we think it's warranted. But if patients don't respond to conservative treatments right away, this is something we can look at to see if surgery might be indicated. This is a nice picture of a 3D ultrasound. And you can see where the red arrows are. They're pointing to the end. That black C is the internal anal sphincter, and you can see it's disrupted. It should go all the way around like a donut. And then the white area around on the outside, that's the external anal sphincter. And again, right in here, it's disrupted. There's also defecography. That can be a really helpful tool. They actually put a radio opaque substance into the rectum and have somebody sit on a commode, defecate while they do fluoroscopy. And it can uncover some things that you might not know about, like internal prolapse. And then functional MRI, they can also do defecography with it, and that can be very helpful. Similar information, but it also gives you more of the anatomy on the functional MRI. So these are tools that you can use for diagnosing people who have fecal incontinence, and they can help guide your treatments, which Dr. Markland's going to talk about next.